Hello, everyone. So, we are here again for our next episode of 4D 3.0. And today we'll be having discussion on a very interesting topic, the talk of the town nowadays, which is obesity. We'll be discussing how obesity affects our different systems. And for this discussion, today we have a great panel. We have Dr. Rajesh B. Burkunde, who is a cardiologist from Telangana. Welcome, Dr. Rajesh. We have Dr. Akhila Reddy, who is an endocrinologist, again from Telangana. Welcome, Dr. Akhila. And we also have a nephrologist, which is Dr. Ajay Kumar Patil, again from Nizamabad. So,
Thank you.
we have a great panel over here who will be discussing the nuances associated with the management of obesity, and that too pertaining to different systems. Dr. Ajay, let's begin with the heart. So, how does obesity affect heart, and how has this disease, understanding of this disease over the decades, changed your practice as a cardiologist?
Hi, good evening, sir, and good evening to all. So let's begin with the heart. Heart is a very important organ of the body. So once the obesity is there, then everything, the blood volume, heart has to pump more blood. There'll be an increase in the afterload. There'll be increase in the preload. So heart has to pump forcefully. With increase of BP, with all sorts of factors, then ultimately there'll be a stiffening of the heart muscles. There'll be a fibrosis because of all factors like RAS activations and insulin resistance and the infiltrations of the fat in the atria and ventricle. So it will ultimately lead into the fibrosis, and ultimately there'll be a diastolic dysfunction. So diastolic dysfunction is the more common thing. Many times we get the patient who says other doctors are saying like ejection fraction is normal 60%. Even then patient has a shortness of breath, and ultimately that patient has diastolic dysfunction. So diastolic dysfunction is underdiagnosed term, and ultimately it will lead into the heart failure and the arrhythmia. Most common arrhythmia is atrial fibrillation. So this patient ultimately develops a heart failure with preserved ejection fraction. So the ejection fraction will be normal, but they'll be presenting with the heart failure. So that is the everything about the heart.
Yeah, thank you, Dr. Rajesh. Like you were telling that it is obesity affects heart both directly as well as indirectly in both ways. We absolutely agree with you. Dr. Akhila, I think over the past few months, obesity has become a big thing, especially for us endocrinologists. How your practice has changed over past 1 or 2 years after we have medications per se to treat obesity. How frequently are you looking for this problem in your patients now?
Yes, sir. So first we'll look into the prevalence of obesity in our people. So over the past decade, we can say that it is almost rampantly increasing the prevalence of obesity in our day-to-day OP practices. So it has multiple causes because of our lifestyle, because of our food habits, and lack of physical activities. So multiple issues have been playing a significant role in the increasing the prevalence of diabetes in our population. So that is obvious, and the understanding of the obesity in the population, so the perspective, the thinking of the population is also a little more better towards, at least in the educated population, that it's not a simple obesity like healthy kind of thinking in rural areas. Previously, Uh, like if the child is obese, they used to think that acha hai baby, acha hai. But now the scenario has completely changed. So if the baby is growing well, it is obviously a negative marker in present era. So that concern is a little brought into the patients by into the social media. So multiple factors have played a role in bringing the concept of obesity and its side effects into the population mindset. And coming to the treatment and the patient approach to the hospital, it significantly increased, obviously. But concerning the prevalence of diabetes in the previous, like about like 5-6 years back, it was less. And for that ratio and the present ratio of prevalence, I don't think that the people have that much proportionately increased to the treatment yet. I feel that. So, not completely. The rise is more than the awareness and the patients turning to the treatment of obesity. And luckily, at this present point of time, we had like a good number of drugs which had significant effect in the treatment. So it had made our efforts easy to reduce the obesity or just to counteract the obesity in the patient population now.
Yeah, I absolutely agree with you, Dr. Akla. And over the past few months, what I have seen in my clinical practice is that I have uh, patients who are completely divergent to each other. In the morning, I was trying to convince a 120-year-old patient who has been having multiple problems, OSA, osteoarthritis, fatty liver, and I was trying to convince him to start a GLP GIP combination. And by the evening, I got a call from a young girl, and the call was, "I'm getting married in next 5 months, and I want to lose those 5 kgs. Will you prescribe
Yeah,
me a
yeah,
GLP-1?"
yeah,
So this is what we have been seeing in our clinics
yes, yes,
after the
yes,
availability of these drugs. But good thing is, I believe with this noise, now people have started understanding that yes,
yeah,
obesity is a problem.
yeah.
Dr. Ajay, we have talked about the endocrine perspective as well as the cardio perspective. But how does it affect kidneys? Are kidneys just a bystander to obesity, or obesity per se also directly affects kidneys?
Actually, I have discussed with related to other organs. Obesity actually affects kidney, and this is very one of the very most neglected you can topic you can say, especially in nephrology at least. Nobody can believe somebody is obese because average BMI of Indians is on higher side, and the lifestyle and many things do contribute. So it does completely actually changes the hormonal balance, the hemodynamics, and which affects as in case of heart or endocrine system. Ultimately, it comes down to kidney, especially the as the you can say oxidation or increased fatty acid synthesis in case of obesity, that does increase the pro-inflammatory markers and decrease adiponectin and the you can say rise in other harmful enzymes, hormones, which ultimately act as a pro-fibrotic, pro-inflammatory to kidney, ultimately affecting the GFR. So we can say obviously it actually, I would say, it directly affects, but not very immediately, but it slowly changes the whole metabolism, and all the metabolic pathways are involved ultimately, and ultimately pro-inflammatory markers plus fibrosis affecting the glomerulus and causing the hyperfiltration, and slowly the hyperfiltration going to get affected the glomerulus. So ultimately GFR over the period of time, GFR will surely go down. So that is the thing.
Yes, like you were saying, it directly affects kidneys as well, and there are certain types of glomerulonephritis also that are directly associated with the obesity, and like you were telling, it leads to production of cytokines, which leads to not only renal problems but also further increases the metabolic problems associated with obesity. Uh, so, what are the current guidelines, Dr. Rajesh? What does the guidelines say? What are the drugs that are available for management of an obese heart? If we can use this term, I believe if there is a term like obese heart. So, what are the medications that are that you are using currently?
Yeah. So basically, what is the thing is in obesity, definitely this is a known term now, obesity cardiomyopathy. So definitely we have to decrease the this diastolic dysfunction. So we have many drugs, but basically we have to reduce the risk factor. If the patient has a hypertension, if the patient has a diabetes, if the patient has any other comorbid condition, so we have to treat that. So ultimately diastolic dysfunctions will come down, and ultimately we have to treat the obesity. So for obesity we have many drugs, but for diastolic dysfunction specifically there is so much of noise for this GLP-1 agonist. So we also started using GLP-1 agonist for this diagnosis. So ultimately basically we have to treat the risk factor which leads into this. So we have this specific drugs, and there is no specific drugs which can reduce the diastolic dysfunctions. So obesity is the multifactorial disease which can affect all systems. Like basically it will increases your inflammatory markers and your RAS system, and there'll be increase afterload. Everything is boils down into the ultimately the heart failure. So before that we have to treat this thing. So ultimately there is no specific drug that will treat the diastolic dysfunction for this etiological factor. So basically we have to treat the obesity.
Yeah, so it is predominantly obesity that has to be taken care of, and you also see a lot of patients with heart failure. Heart failure, I believe, one of the things that connects all three of us, and regarding a patient with obesity, we see patients with heart failure. Any other newer drugs that you are currently using for heart failure per se? If I say directly heart failure, especially in a setting of CKD, what medications are you using?
So there are 4 pillars to treat the heart failure. So it's basically if the heart failure with reduced ejection fraction, so we have a 4 pillar of the heart failure. That is one of this is beta blocker, and beta blocker ultimately will reduce your sympathetic drive. And there is a oversympathetic drive in the obesity also. So one is the beta blocker that will prevent the arrhythmia, that will prevent your sympathetic drive. The second is the mineralocorticoid receptor antagonist. So that is the second pillar in the heart failure. Third pillar is the your SGLT2 inhibitor. So SGLT2 inhibitors, we have many studies and which shows that the SGLT2 inhibitor has a clinically significant effect in the heart failure with reduced ejection fraction, even in the heart failure with the preserved ejection fraction. So and we have other ancillary drugs, and now we have verapamil. These are the drugs that we can use in the heart failure with reduced ejection fraction, and these are the 4 pillars of the heart failure with reduced ejection fraction, even in the preserved ejection fraction.
Absolutely right, Dr. Rajesh. Dr. Ajay, same question to you. The CKD with CHF, what are the drugs you are going to use? Diabetes. So the patient is a diabetic, obese, and is having CKD, CHF. What are the drugs as a nephrologist you will prefer first?
You mean to say especially in case of obesity or just CKD and CHF?
CHF and obesity is always a part. I think 80% of my
Yes. I do. No, there are means see that purely in case of obesity related glomerulonephritis, there are as we all know, primary care, what we see, lifestyle modification, weight loss. Weight loss is the most important thing, and I would like to just focus on one of the main point, that bariatric surgery. Obviously it's indicated in very in case of very high BMI, and its indications are different, but it does help. and it does help scientifically. There are some papers which have shown that when adipose tissue load is reduced, in that case, the secretion of adiponectin increases and other harmful hormones decreases, and that does help in case of CHF, CKD, and in general health actually. And besides that, in case of medicines, what we do use is that GLP-1 again receptor agonist and SGLT2 inhibitors, especially the apagliflozin, empagliflozin. That's what I think. Two things I'm preferring. And besides that, the newer drug there is Finrinon. So Finrinon I have started using on some of my patients, which is actually helping. It has shown in some trials. I'm not sure about the how the what were the number of patients were considered, but it did show that there is in long term the decrease in GFR is lesser in patients with Finrinon, and also it does help in case of CHF. So these three drugs I am using currently.
So before we go to next question, Dr. Akhila, again similar question to you. Same patient now is visiting you.
So,
What are the drugs that you like to avoid as an endocrinologist, and what will be your preferred drugs in such a scenario? CKD, CHF.
yes. Preferable drugs usually. So presently, the SGLT2 inhibitors, considering all these put together, like the heart failure and CKD, SGLT2 inhibitors will be for sure the first line drugs which cannot be avoided actually. So which are definitely need to be given for those patients. Considering GLP-1 receptors in the treatment of obesity, so the negative side is, for example, most likely if the heart failure is like the antecedent cause, if it is not due to the atherosclerotic event, if it is more likely because of only the heart failure as such, or it is a diastolic dysfunction which is not related to atherosclerotic events, probably except for the weight reduction, not much help is going to be done with GLP-1 receptor agonists. So because they have more prominent effect on the atherosclerotic events rather than the heart failure as such, in the trials which have been studied for the positive benefits on the cardiovascular outcome trials. So first we need to stabilize the heart and the CKD progression, and later on probably the primary cause obesity also needs to be addressed after stabilizing the comorbid conditions with the GLP-1 receptor agonists, or lifestyle if they are definitely counseled, or they are willing to, their body is like without any osteoarthritis which prevents them from doing this physical activity or exercises, which are also part and parcel of treatment of obesity. So depending on that, first for sure drugs are SGLT2 inhibitors, and later on like Finrinon, definitely to avoid the progression of CKD, add-on benefit. And later on, depending on the severity of obesity scale into which the patient lands, and if they are adequately counseled, not so severe BMI like more than 27 or 28, so can be brought down with lifestyle modification, can avoid GLP-1 agonists.
Any other drug you like to avoid, especially because the patient is having CKD? Any drug which will lead to hypoglycemia? I'll personally like to avoid sulfonylureas in such a scenario, because
Definitely. Yeah.
it may lead to hypoglycemia and it may exacerbate
Yes,
CHF.
definitely. And we need to titrate, even because when we are treating the heart failure, we are going to add the SGLT2 inhibitors, and definitely the previous oral hypoglycemic drugs needs to be modified. And even we have seen, like in the clinics, we have observed that post myocardial infarction or the post cardiac events, immediately after the treatment for the cardiac treatment, that anti-inflammatory effects, most of the patients come with the lower blood sugars in that period of time post cardiac events than the quantum of sugars which were there just prior to the cardiac events, because that is the anti-inflammatory effect of the drugs which has reduced the blood sugars for that period of time. and again they may land in hyperglycemia after like 15 days or so post MI. So all these needs to be considered definitely in the treatment.
Yeah. So
There is a one question always. Whenever the patient comes, there is a two things like acute decompensated heart failure and the compensated heart failure. So whenever the patient comes with the acute decompensated heart failure, so obviously we have to start this all four pillars. But depending on the renal condition, there is a cardiorenal syndrome, type 1, type 2, and all. So basically, we have to add this all four pillars like ARNI, ARBs, MRAs, and SGLT2 inhibitors and beta blockers. So there was a consensus earlier that we have to start sequentially, and now that is a rapid sequence they have added in that. So if patient comes with acute decompensated heart failure, they'll have a creatinine of like 1.52. They'll have a cardiorenal syndrome. So we need to be cautious while adding this ARNI or ARBs and your MRAs. So depending on the condition, if the patient is in shock, then depending on again beta blockers has to add or not. So now the guidelines is suggesting we should do the rapid sequencing, and the first drug to be added is almost we can add this is SGLT2 inhibitor. So SGLT2 inhibitor always can be a first drug to add in acute decompensation also.
yeah, we absolutely agree. So I believe all of us agree that SGLT2 inhibitors are one drug that can be used without any problems. Either it is the endocrine OPD, nephrology OPD, or cardiology OPD. How do we monitor the safety? Because I believe we are using multiple drugs. As a cardiologist, Dr. Rajesh, what do you look when you have started these patients on all of these drugs? What are the safety parameters that you follow?
Generally, in acute decompensated heart failure, we have to see always the creatinine. So that is a major concern. If patient's creatinine, if the patient is in CRF, then we need to be very cautiously. We need to add this ARNI, ARBs, or your mineralocorticoid receptor antagonist. So that is very important. We need to see. Then we need to see the LV ejection fraction. Obviously, depending on that, we need to add the other drugs, and that's the questions only. And other thing is the BP. We have to see, depending on the BP, if the patient is in cardiogenic shock and all. So we need to cautiously add the drugs. So these are the things generally we look in the clinical scenario when the patient comes with the ADHF. And ultimately electrolytes and all, we have to see if the potassium is like high, then definitely MRAs and your ARNIs has to give later. Right?
Anything else, Dr. Ajay, you'd like to add over here? What do you follow in your practice? How do you look at these patients?
Sir, especially in case of SGLT2 inhibitor, as a nephrologist, before starting, I always look for complete urine examination, because SGLT2 inhibitors, as there will be glycosuria, so leakage of glucose in urine obviously will keep the patient at risk of increased risk of UTI. So if somebody has more pus cells than normal and has comorbidities, unhygienic habits, in that case I would avoid SGLT2 inhibitors. Besides that, regular follow-up for UTI, especially who are taking all these medicines, they are doing well, but UTI sometimes prohibits me to giving the SGLT2 inhibitors. Besides that, in case of CKD, I always look for the, you can say, non-alcoholic fatty liver disease presence. Whether now there is new term that metabolic dysfunction associated fatty liver disease. So I always look for hepatic involvement also in case of obesity, because the pericentral obesity is more important in case of obesity related GN. So same way the fatty liver, especially non-alcoholic fatty liver, you can say MAFLD, both are, you can say, are they are good indicative of likely progression of CKD or causing CKD. So though being nephrologist, I look for all the renal parameters, I always look for the hepatic involvement also. And besides that, Now you can say, as Rajesh sir has already mentioned, that electrolytes monitoring and hyperkalemia, you have to take care of hyperkalemia. So these are the best.
Thank you, Dr. Ajay. Dr. Akhila will be now slightly going off target now because endocrine system is something that is affected more than any other system with obesity. So I just had a patient today in the morning, and again this patient is 119 kgs and is already on GLP GIP combination, and he has been married for past 6 years, and they are planning for pregnancy now. The couple is planning, and his semen parameters were not looking great. So we have been seeing a lot of patients with hypogonadism associated with
Yes.
obesity. How do you manage? What is your take? Do you see such patients, such female patients also?
So, female patients actually most commonly associated problem is primary infertility. Most commonly, the antecedent cause will be the PCOS. Definitely, the primary treatment for the couple, if they are willing to have like if there is a time constraint, most of the people, if they are sufficiently educated, they understand the concept of normalizing the PCOS, then going for ovulation induction and conception. But some people primarily are motivated only for ovulation induction and the conception. So the two priorities will be different in treatment of the patients. So, but we try to counsel them regarding the advantages of prioritization of treatment of obesity and the positive feedback of this PCOS treatment on the ovulation treatment, which they are going to have in the later period of treatment. So, obviously, first part of this is counsel the patient regarding the advantages of treatment of obesity with GLP-1 analogs or whatever which are available and the patient is willing to take for the treatment of obesity, so that the PCOS is ameliorated, not completely cured, because we cannot, as such, cure the PCOS unless the obesity is tackled. So, this treatment can ameliorate the hormones. See, adipose tissue is a major source for the testosterone in the people with PCOS. So, that if testosterone, the source of testosterone is decreased, automatically the ovulation inhibition from testosterone is reduced. So, the chances of, we cannot say that the normal conception is easy without any ovulation induction, but the chances of conception, at least with oral ovulation induction treatment, and the chances of going to IVF may be reduced if we tackle the PCOS in these patients.
You are absolutely right, Dr. Akhila. And weight reduction is the key here. And again, in my patient also, we did suggest him that around 10% of weight reduction will improve his parameters by quite a lot.
Yes.
And do you use gonadotropins in such situations, especially in males? Are you using gonadotropins
I didn't use still.
for improving semen parameters? So,
Actually, for my clinical practice, very few male patients come to me, sir. Females, yeah, lot many come. Males, very few. Yeah.
So yeah, so there is data. So we are using, and we had a couple of patients, and the fertility improved significantly. And two of my patients conceived also with use of. So we used both weight reduction with the newer drugs as well as HCG for these patients, and one of my patients have conceived, another his semen parameters has improved a lot. So probably
Definitely, it is hypogonadotropic hypogonadism. Definitely should be responsive to gonadotropins.
yeah. So we have talked about heart failure. Dr. Rajesh, how difficult is to pick, or what advice will you give me so that I'm able to pick the patients with, especially with HFpEF, my OPD. As an endocrinologist, I see a lot of diabetic patients, and we have a lot of patients. Of late, I have been seeing them a lot. And what one thing should I look for so that I'm able to pick them early in my OPD?
So clinically, if you are getting the patient with the shortness of breath, say probably class 2 NYHA class 2, and if you don't find any reason for that, there is no OSA, there is no COPD, there is no lung issue, or there is nothing, then you can probably think of HFpEF, heart failure with reduced ejection fraction. So that is a clinically only you can think of, like this patient may have diastolic dysfunction and HFpEF. Then with investigations, we have many things like NT-proBNP. If you can send, then if it is raised, then definitely. But clinically, if you are seeing the patient with shortness of breath with no explanation in the respiratory system and other, then definitely you can think of, especially if the patient has a risk factor that can lead into the heart failure, just like obesity, just like diabetic cardiomyopathy, then you should definitely think of and you should refer the patient for the echo for detailed evaluation for the diastole.
So, Dr. Rajesh talked about use of markers like NT-proBNP. How CKD affects these markers? Does it lead to a false positive or a false negative in such a scenario that I should be aware of in my OPD? Because both of these are very coexistent. Because we see patients with high creatinine and having breathlessness, and we get a test like NT-proBNP, and it turns out to be a high. So, are there any changes associated with CKD in these lab results?
Yes, sir. Actually, in CKD, many of the markers, they are falsely elevated. Not in all cases, but the sensitivity, that specificity does go down. That is normal. Even in case of myocardial infarction, you can say sometimes we do troponin INT, CKMB. In fact, they are usually high in case of CKD, not more than normal. So we can't just label them as MI. Same way, in that case, the guideline says that you have to keep checking titers. And if it is increasing titer and more than 20% increase in the titer at serially intervals, then you can consider label as MI, provided there are other evidences like ECG changes. For example, this is for MI. Same way, NT-proBNP, many of the you can say situation, it does give falsely positive or higher level as compared to normal healthy patient. So in CKD, that is there. So in that case, we have to correlate clinically. Yes.
So actually, we have to correlate clinically also. If patient has a typically chest pain and his tropi is high, there is many things that can raise the tropi. One of the reason is CKD. Then any infection, any inflammation in the body, even you will get. Even tropi is very specific for heart, but even then tropi also you may get raised in many conditions like simple myocarditis and or simple any your acute febrile illness also you may get the tropi positive, but that will be mild positivity there. So you have to just correlate with clinical scenarios and other conditions also.
Yeah. Dr. Akhila, how frequently do you get NT-proBNP done in your patients? So it is difficult for me to get in my clinic because
Yes.
costs and it is difficult just to convince them. I believe it is more easy for Dr. Rajesh to convince them to get an
That is so difficult for me even, sir. Because
so another
Unless the patient has very compelling symptoms like evidence of pedal edema and all. But in that case, we don't usually go for pro-BNP because it is clinically evident that it is heart failure. So very subtle symptoms, the patient to convince that it is a heart symptom and refer to a cardiologist is a difficult thing. Forget about the pro-BNP.
So I believe it is similar.
Many patients will say हमारा इको तो normal है फिर और ये 4000 का टेस्ट क्यों करना है.
Okay.
Yeah.
Exactly. Um, Dr. Akila, you also see a lot of patients, so that is what I also see in my OPD. A slightly elevated TSH,
Yes, sir.
and they'll come to your OPD, and the their lives, every problem is because of of that.
Yeah.
You-
Yeah. Yeah.
How do you convince those patients that it is the weight
Yes.
that is responsible,
Yeah.
and
So
and
if the patient is coming from a city side, I'll give time to explain about the TSH elevation. Just 2-3 minutes. If their understanding level, I prefer that they will be convinced about that. So if their education status at least is compelling me to explain that, so I just give 2 to 3 minutes to explain that this is a problem of obesity, which has increased the TSH of yours. If you lose it, it may come down. So it is not problem with the thyroid gland. So if the patients are convinced that it is a simple thing and can be ameliorated by lifestyle modification, they tell. If I see their facial expression that the doctor is saying nothing, it is like I have a big problem, but she's convincing that that is a normal issue, nothing to do with that. So I just go for a little lower dose of simple thyroxine treatment and ask them to review back again. Because the placebo role of thyroxine is more effective actually, rather than to avoid tablets and asking the patient to come back after 3 months. They are not going to come back.
yeah. So yeah, exactly. I believe a TSH of 6.5 is whenever we see that report in our OPDs, we understand that for next 15-20 minutes there is going to be chaos outside my room, because that is the amount this patient is going to take. Uh, so I believe we had very good discussion on obesity and its problems, and we have been discussing this for past 50-55 minutes now. So before we sign off, I'll just have last words from you all. Dr. Ajay, we'll start from you. Obesity is CKD. What messages would you like to give to your patients? How to go about? How to diagnose? What are your last words on this?
I'm myself working on the same, and hopefully I will also be able to convince my patient. So for CKD and this obesity, obviously basic lifestyle modification first of all, then diet, good healthy diet, and regular exercises. Besides that, this everybody knows this, all is primary intervention. But besides this, as a nephrologist, if somebody I suspect obesity with CKD, in that case, obviously I will look for his obvious symptoms. Like there are two kind of CKD. You can say early stage and late stage. Early stage patient may not develop symptoms. In that case, basic IFT renal function test with electrolytes, creatinine, and complete urine examination, and you can say proteinuria. That is the urine protein create ratio, which will give me very clear cut evidence and early diagnosis of obesity related GN, possibly obesity. You can't 100% it's confirmed. Besides that, as I already told that is obesity related GN I suspect, in that case I will look for fatty liver also to rule out possibility. And besides that, I will have to first confirm the obesity related markers also. For example, the basic first clinical parameters like waist hip ratio, BMI, and besides that, uh, theoretically we can do all hormonal level, but we don't do obviously. But this is how I approach at least to CKD with obesity. And in late stages, patients with overt symptoms, they will present like pedal edema, dyspnea, and clear-cut evidence of rise in creatine. So that's how I think I will usually go about it.
Yeah, uh, uh, that's you have actually said all everything that a person needs to know. It is the lifestyle modifications, and it's not just one organ that is affected. You need to look at the patient as a whole. You need to look at the liver. You need to look at the hormones. You need to look at the renal parameters, at the heart also. Absolutely right, Dr. Ajay. Dr. Rajesh, I believe one organ that is affected, that is acutely affected, I believe, I'll rather say this, and it is affected in a way that we require you in an emergency. Uh, CHF with this obesity and diabetes. Your last words, especially for clinicians, what they should be worried about when they look at such a patient. What is the long-term prognosis of such patients and how to take care of these patients?
So basically, first of all, for the patient perspective, the insulin resistance is the most dreaded things, and we have to improve the insulin sensitivity. So all the measures which can improve the insulin sensitivity, that has to be done. So all packaged food which contain the trans fat or partially dehydrogenated fat, we have to avoid that, especially after 30-40 of age. All sugar, all form of sugar, we have to avoid. That is a basic thing. And then we have to include the fibers in our diet. It's almost 25 to 30 grams of fiber per day. Then we have to increase the protein contained in our diet, almost 1 grams per kg per weight. We have to include in our diet, so that and obviously to avoid the complex carbohydrate load and all sugars. So these are the basic things which can, and the most important thing along with this is resistant exercise and possibly a resistant exercise, which can give you the maximum benefit to improve your insulin sensitivity. So all boils down to the insulin sensitivity, because resistant insulin cannot increase your nitric oxide and cannot vasodilate. So you will have high BP, you will have PCOD, you will have everything like diabetes and everything. So this is the perspective for the patient perspective. If the for the clinician, if they find the patient with ST elevation on the ECG, if the angioplasty center is nearby within a 1 hour, then they can refer directly with loading dose, with aspirin, with rosuvastatin, with the clopidogrel, with loading dose. And then within 1 hour, we can do the angioplasty, we can open the artery, so that we can save the myocardium. If the angioplasty center is not in the vicinity and within the 1 hour, then they can thrombolize the patient with the thrombolytic agent, so that with loading dose and thrombolytic agent, and then they can refer the patient to the angioplasty center. So and any patient, why patient, if known case of any MI and with reduced ejection fraction, then such a patient, especially in winter season, they'll come up with acute decompensated heart failure. So we have to rule out any electrolyte imbalance, we have to rule out any infections, we have to rule out any new infractions. So these are the things we have to rule out. Especially they'll have a respiratory infection, they'll come with the ATHF, they'll have pulmonary edema and all. So we have to treat meticulously with this all sort of small infections, so that they won't go into this acute decompensation, who is a known case. So these things to be done. Yes.
Thank you, Dr. Rajesh, for meticulously telling us how to go about, especially in acute situations. Dr. Akhila, since I believe obesity is a metabolic problem, so we want the last words from you. Diabetes with obesity, how to go about, what drugs to use, what to avoid, how to go about it.
So, yes, sir. The most common association will be obesity with diabetes. So, unless the diabetes is there, the patients are not worried about obesity. Frankly saying, unless it turns out to some end organ damage, they're not going to come to the treatment. So that concept that needs to be counseled, or the awareness has to be created in that perspective actually. So, because most of the patients who will be coming for the obesity clinics or the diabetic clinics, immediately after diagnosing, suppose at around the age of 30 years or 25 years, they are worried about the reversal part of diabetes. So in that case, actually, whatever the chance has been there at that point of time prior to that, like pre-diabetic stage, if they had a little concern about their health, it would have been prevented. So I had a patient like few days back. He had diabetes at around 35 years of age, and he's now almost 10 years past diabetes. And now he comes to the clinic just for monitoring of his diabetes and his health checkup. And he gives a question that whatever about my diabetes and reversal, it is absolutely maintained in the normal levels. So I have said that, like, to be counseled, see, the prevention stage of diabetes is now with your children. That has to be inculcated in your children at about 10 to 15 years of age. That awareness has to be created. Not after the onset of diabetes or after completely insulin depletion in the pancreas, at that point of time, no one is, helpless to at this reversal stage is not possible. So that part of inculcation is more important. So I usually counsel about the prevention, at least for their next generation people, or to counsel about the risk factors. See, if your parents or immediate relatives had something like a CAD or a CKD or something, end organ damages or a hypertension, accelerated hypertension, whatever. So just think about those incidents in your family and how are they going to link with you in your future. So if they are completely negative, no events, probably he might be at a lesser risk in this population. But that awareness has to be created. Not only thinking about their past inheritance of properties, but these have to be first prioritized. What are the medical histories in the parents is absolutely important. And coming to the treatment, obviously, so obesity and diabetes has to be treated from the patient perspective. If we are thinking to manage obesity or diabetes alone, it's not going to comprehensively treat the diabetic patient. And the patient has to be under follow-up. So most of the patients think that the simple blood sugar monitoring every 3 months is enough for me, and they disappear from the clinic for about 2 years. This they monitor at home. They're not aware of elevation of creatinine, eye effects of diabetes, unless there is a overt symptom, completely like hemorrhagic retina or bleeding to the retina and sudden vision loss. They don't turn up and land in such complications. So has to be counseled. It's not like hypertension, just take a simple pill, monitor your BP, nothing is going to happen. It's diabetes, to monitor sugars is equally important, and the end organs treatment is also important in monitoring.
Yeah, thank you, Dr. Akhila. So I believe we had a wonderful session today. We talked about obesity and how it is a problem in managing our patients and how it affects our patients' lives. Our experts talked about holistic management. Our experts talked about it is not just one system that is affected. You need to look at the patient as a whole, and you need to look at every problem, and then you have to individualize the treatment, because if you are compartmentalizing the treatment, then it will not be helping the patient that much. So I'm afraid with that brings us to the end of this program. Thank you, Dr. Rajesh, Dr. Ajay, and Dr. Akhila. It was wonderful talking to you all, and we'll be joining all of you again in next episode of 4D 3.0. Thank you.
Yes,
Thank you, sir.